This is the audio lecture for Chapter 21, Postpartum Complications. Providing safe and effective care of the woman and family experiencing postpartum physical or psychologic complications requires a collaborative effort from all members of the healthcare team. This audio lecture focuses on the postpartum complications of hemorrhage and infection and psychologic complications. Postpartum hemorrhage. Postpartum hemorrhage is among the leading causes of maternal death in the United States and worldwide. It is a life-threatening event that can occur with little warning and is often unrecognized until the mother has profound symptoms. Postpartum hemorrhage is defined as the loss of 500 mils or more of blood after vaginal birth and 1,000 mils or more after cesarean birth, or either a 10% change in hematocrit between admission for labor and postpartum, or the need for blood transfusion. Postpartum hemorrhage is classified as early or late with respect to the birth. Early, acute, or primary postpartum hemorrhage occurs within 24 hours of the birth. Late or secondary postpartum hemorrhage occurs more than 24 hours but less than 6 weeks after the birth. Etiology and risk factors. Uterine atony is marked hypotonia of the uterus. Uterine atony is the leading cause of early postpartum hemorrhage. It is associated with high parity, polyhydramnios, fetal macrosomia, and multifetal gestation. In such conditions, the uterus is overstretched and contracts poorly after birth. Other causes of atony include traumatic birth, use of halothane, magnesium sulfate, rapid or prolonged labor, chorioamnionitis, and use of oxytocin for labor induction or augmentation, and if the mom had issues with uterine atony in her previous pregnancies. Lacerations of the genital tract. Lacerations of the cervix, vagina, and perineum can cause postpartum hemorrhage. Hemorrhage related to lacerations should be suspected if bleeding continues despite a firm, contracted uterine fundus. This bleeding can be a slow trickle, an oozing, or frank hemorrhage. Factors that influence the cause and incidence of obstetric lacerations of the lower genital tract include operative birth, precipitous birth, congenital abnormalities of the maternal soft parts, and a contracted pelvis. So if you have a mom who delivered and you palpate the fundus and her fundus is nice and firm, but you still notice that she's still having trickles or gushing of blood, this leads you to suspect that maybe there is a laceration. Maybe it's of the cervix, of the vagina, or somewhere on the perineum. So if you notice this, you have a firm uterus, but your mom is still having an excessive amount of bleeding, you have to start thinking maybe there is some type of laceration that wasn't repaired after the delivery of the baby. Hematomas. A pelvic hematoma is a collection of blood in the connective tissue. It can be vulvar, vaginal, or retroperitoneal in origin. Your vulvar hematomas are the most common. Pain is the most common symptom, and most vulvar hematomas are visible. Vaginal hematomas occur more commonly in association with a forceps-assisted birth and episiotomy or prima gravity. If the woman reports persistent perineal or rectal pain or feeling of pressure in the vagina, a careful examination is made. Hematomas are usually surgically evacuated. Once the bleeding has been controlled, the usual postpartum care is provided with paying attention to pain relief, monitoring the amount of bleeding, replacing fluids, and reviewing her labs to make sure she didn't lose too much blood. So you're going to check her H&H. Retained placenta. Now, when we're talking about late postpartum hemorrhage, it is usually the result of infection, subinvolution of the placental site, retained placental tissue, or coagulopathy. Now, when the placenta has not been delivered within 30 minutes after birth, despite gentle traction on the umbilical cord and uterine massage, it is described as retained. Initial management of a retained placenta consists of manual separation and removal by the physician or the midwife. And with manual separation, the doctor or the midwife puts their hand inside of the uterus and manually removes the placenta. Sometimes if we're going to do a manual removal, we'll take the mom to the operating room, give her a little sedation, and then remove it, because if you can imagine, it can be quite painful. Fragments of the placenta can remain in the uterus after spontaneous separation of the placenta during the third stage of labor. In this case, the woman will have excessive bleeding and the uterus will feel boggy due to uterine atony. Typically, if we have to manually remove a placenta, we're going to follow up with ultrasound to make sure that we got every piece of the placenta. You want to make sure that you completely evacuate the uterus. If not, the mom will not be able to, that uterus will not be able to clamp down and contract, and it's going to put the mom at risk for postpartum hemorrhage. Adherent placenta, I'm not going to talk too much about this because this is kind of a higher level thing. But when we're talking about adherent placentas, these are placentas that attach too well to the uterus. So with your placenta accreta, the placenta will actually penetrate through the myometrium of the uterus. Through placenta increta, there's a deeper penetration of the placenta in the myometrium. And with placenta percreta, the placenta will actually grow all the way through the uterus, and it can grow outside the uterus and attach to other abdominal organs. Either of these are considered a high risk, and usually, depending on how deep the placenta is embedded into the uterus, these moms, typically we will do what we call a C-hyst. We'll take them back, do a C-section, and then they would probably have to get a hysterectomy, because if you don't completely take the placenta out, the uterus is not going to contract and the mom is going to bleed. So typically, if we have problems with adherent retained placenta, usually we surgically do C-section and then hysterectomy, especially if we cannot control the bleeding. Inversion of the uterus. Inversion, or turning inside out of the uterus after birth, is a potentially life-threatening complication. The incidence of uterine inversion is approximately 1 in 3,000 births. Now, the easiest way to prevent inversion of the uterus is not pulling on the umbilical cord unless you're sure that the placenta has definitely separated or detached from the wall of the uterus. Like I said earlier, we give the placenta 30 minutes to deliver, and usually with gentle traction and massaging of the fundus, the placenta will separate. Sometimes you get doctors that are a little too eager and they pull on the cord, and two things can happen. You can do what we call eviscerate the cord, or that means the cord tears away from the placenta, and if the physician or midwife eviscerates the cord, they have to go in and do a manual removal. Or if you're pulling on the cord, you can invert the uterus. You can actually pull the uterus out. Uterine inversion is an emergency situation requiring immediate interventions that include maternal fluid resuscitation, replacement of the uterus within the pelvic cavity, and correction of associated clinical conditions. Subinvolution of the uterus. Late postpartum bleeding can result from subinvolution of the uterus, which is a delayed return of the enlarged uterus to normal size and function. Causes of subinvolution include retained placental fragments and pelvic infection. Signs and symptoms include prolonged lochial discharge, irregular or excessive bleeding, and sometimes hemorrhage. A pelvic exam usually reveals a larger than normal uterus that can be boggy. Treatment of subinvolution depends on the cause. Some of the medications we have, your methergine, methylargonovine. We give 0.2 milligrams every 3 to 4 hours for 24 to 48 hours. If there is retained placental fragments left inside the uterus, we can do a dilation and curettage, which is a DNC. That's a surgical procedure. If the cause of subinvolution is infection, we can do antibiotics as needed. Early recognition and treatment of postpartum hemorrhage are critical to care management. The first step is to evaluate the contractility of the uterus. If the uterus is hypotonic or boggy, management is directed toward increasing contractility and minimizing blood loss. So if the uterus is boggy, you must massage it. The initial management of excessive postpartum bleeding due to uterine atony is firm massage of the uterine fundus, expression of any clots in the uterus, elimination of bladder distension, and continuous IV fusion with Pitocin added to your lactated ringers. If Pitocin doesn't work, we have other medications. We have misoprostol, which is Cytotec. Typically, we give 500 to 1,000 micrograms rectally. We talked about methergine. Now, the only problem with methergine is if you have a patient who has hypertensive or blood pressure disorders, the methergine is contraindicated because if they already have high or elevated blood pressures, the methergine is going to make the blood pressure go up even higher. There's also Hemabate or Carbopros. It can be given IM. Typically, we caution giving Hemabate with women with the history of asthma. And usually if we're giving Hemabate, we usually will give some Lamoltal because one of the side effects of Hemabate is that it can cause excessive diarrhea. Now, in your textbook, there is a box called Medication Guide, Uterotonic Drugs Used to Manage Postpartum Hemorrhage. Make sure you know the drugs that we use to treat postpartum hemorrhage because I can guarantee you will see this again. Okay, medical management. I know we just talked about this, but let's just go over it one more time. Early recognition of postpartum hemorrhage is critical. You want to make sure you see it before your mom starts to have vital sign changes, because once her blood pressure starts to drop and she becomes tachycardic, it's late in the game. The first step is evaluation of contractility of the uterus. So you want to feel the fundus of the uterus to see if it is boggy or if it is firm. If the fundus is boggy, your first step is to massage the fundus until you can get it firm. Management is directed toward increasing contractility and minimizing blood loss. So, if after massaging the fundus for a time you still can't get it to firm up, now we need to start thinking. Let's start with the medications that we can give. And we talked about 4 medications that we can give: oxytocin or Pitocin, your Methergin, your Hemabate, and your Cytotec. Methergin, we cannot give to our women with hypertensive issues, and your Hemabate, we don't give to women who are asthmatic. So make sure you kind of remember those. And then you definitely want to administer IV fluids because you have to replace the fluid loss, and medication to manage the bleeding. Now, if we can't get the mom to stop bleeding with massaging of the fundus and using the medications, what the physician or midwife can do is what we call bimanual compression, which is you stick your entire hand, your fist, into the vagina to hold the uterus, and then you're pressing from the outside. So you have the uterus in between your hands. So one is on the outside, one is on the inside, and you're massaging the uterus. Now, if the uterus doesn't become firm after the bimanual and the mom is still continuing to bleeding, then we have to think of surgical options. Sometimes we can go in and pack the uterus. They can blow up a balloon inside to kind of ligate those arteries. And if that doesn't work, hysterectomy will be necessary. But we try and save the uterus, especially if it's like the mom's first child. We try and do everything we can to save the uterus. But if the mom's life is at stake, we will take the uterus out. Herbal remedies have been used, particularly outside the United States, with some success to control postpartum hemorrhage after the initial management and control of bleeding. However, published evidence of the safety and efficacy of herbal therapy is lacking. Nursing interventions. As the nurse, we must be alert to the symptoms of hemorrhage and hypovolemic shock and be prepared to act quickly to minimize blood loss. Hemorrhagic hypovolemic shock. Hemorrhage can result in hemorrhagic hypovolemic shock. Shock is an emergency situation in which the perfusion of body organs can become severely compromised and death can occur. Vigorous treatment is necessary to prevent adverse outcomes. Management of hypovolemic shock involves restoring circulating blood volume and eliminating the cause of hemorrhage, whether it's from lacerations, uterine atony, or inversion. Critical to successful management of the woman with the hemorrhagic complication is establishment of venous access, preferably with a large bore needle. And if you can get 2 IV lines, that's even better. Fluid resuscitation includes administration of crystalloids, such as your lactated ringers or your normal saline, colloids such as albumin, blood, and blood components. You want to make sure to restore the circulating blood volume. So typically we give the IV fluids rapidly. We can use packed red blood cells. Fresh frozen plasma may be needed if clotting issues happen, and sometimes we may also have to give platelets. Now, the legal tip: the standard of care for bleeding emergencies. The standard of care for obstetric emergency situations such as postpartum hemorrhage or hypovolemic shock is that provision should be made for the nurse to implement nursing actions independently. Policies, procedures, standing orders, or protocols, and clinical guidelines should be established by each healthcare facility in which births occur and should be agreed on by healthcare providers involved in the care of obstetric patients. So, in essence, if we have a mom who's having a postpartum hemorrhage and which is looks like it's leading to hypovolemic shock, we don't have time to waste by calling physician, getting orders. Usually in the OB settings on the postpartum unit, we have standing orders or protocols in case a postpartum hemorrhage happens. So we can initiate the treatment. And while, one nurse is initiating the treatment, maybe the charge nurse or another nurse is calling the physician, letting the physician know what happens. And usually, if we're in like a huge teaching facility, we can have a resident come, or if there's a OB on call that stays in the hospital, that staffs the hospital, we can call them. Coagulopathies. When bleeding is continuous and there is no identifiable source, a coagulopathy can be the cause. The woman's coagulation status must be assessed quickly and continuous. Causes of coagulopathies can include pregnancy complications such as idiopathic or immune thrombocytopenic purpura, which is also known as ITP, or von Willebrand's disease, or DIC, or disseminated intravascular coagulopathy. ITP is an autoimmune disorder in which antiplatelet antibodies decrease the lifespan of the platelets. Thrombocytopenia, capillary fragility, and increased bleeding time are diagnostic findings. ITP can cause severe hemorrhage after cesarean birth or cervical or vaginal lacerations. Von Willebrand's disease is a type of hemophilia. It's probably the most common of all hereditary bleeding disorders. It's rare, but it is among the most common congenital clotting defects in U.S. women of childbearing ages. It results from a deficiency or defect in a blood clotting protein called von Willebrand factor. DIC, we talked about DIC prior, so make sure you just read up on DIC, but you guys should already know about DIC because we talked about that earlier in the term. Venous thromboembolic disorders. They result from the formation of a blood clot or clots inside a blood vessel and is caused by inflammation or partial obstruction of the vessels. The three thromboembolic conditions that are concerned in the postpartum period include your superficial venous thrombosis, which involves the superficial saphenous venous system, your deep venous thrombosis, which occurs most often in the lower extremities, and involvement varies but can extend from the foot to the iliofemoral region. And then your pulmonary embolism, which is a complication of deep venous thrombosis occurring when part of the blood clot dislodges and is carried to the pulmonary artery where it occludes the vessels and obstructs blood flow to the lungs. The incidence of venous thromboembolism varies from about 1 in 1,000 to 1 in 1,500 pregnancies. Thromboembolism can occur in each trimester of pregnancy and in the postpartum period. Typically, your DVT occurs most often during pregnancy, and your PE is more common in the postpartum period. The primary cause of thromboembolic disease is venous stasis and hypercoagulation, both of which are present in pregnancy and continue to the postpartum period. Women who have C-sections, that nearly doubles their risk for obtaining a venous thromboembolism. That's why we place them on the SCDs, the compression devices, and typically we have them ambulating within 12 to 24 hours after their surgery. Your clinical manifestation is going to depend on the type, if it's superficial or if it's a venous thromboembolism. But typically, your superficial thrombophlebitis is characterized by pain and tenderness in the lower extremity. Physical exam may reveal warmth, redness, and enlarged hardened vein over the site of the thrombosis. Deep vein thrombosis is more common during pregnancy than in the postpartum period, and is characterized by unilateral leg pain, calf tenderness, and swelling. Now, your book talks about positive homing signs can be present, but typically, like I said earlier, we really do not elicit the homing sign on our postpartum women or our pregnant women, because if it is a clot there, we could dislodge it. So basically, it's an assessment. Does a mom complain of pain in the calf? Is it tender to touch? Is there swelling? Is there warmth? Is there redness? And then with your acute pulmonary embolism, the presenting symptoms are dyspnea and tachypnea. Other signs and symptoms that you may see is tachycardia, apprehension, chest pain, cough, hemoptysis, elevated temp, and syncope. Medical management, make sure you read over that. You guys should be familiar with that since we talked about DVTs when we did CODA 1. So make sure you read over medical management. But typically, you know that if it is a deep vein thrombosis, we usually start them on heparin, bed rest, elevate the affected leg, and analgesia for the pain. So make sure you look over that. And typically, in the hospital, once we start to wean them off the heparin, we would start the Coumadin or the warfarin while they're still in the hospital. So make sure you look over the medical management of DVT. That should be review for you guys. For the nursing interventions, while in the hospital, nursing care of the woman with a thrombosis consists of ongoing assessments, inspecting and palpating the affected area, palpating the pulses, checking for pain and tenderness in the calf, measuring and comparing the leg circumference, inspecting for signs of bleeding, monitoring for signs of PE, and then looking over the mom's laboratory tests and definitely checking her respiratory status. You also want to teach the woman the signs and symptoms that she needs to report to her physician, pain management, elevating the leg, things like that. You definitely want to educate the mom on what to do, what not to do. Postpartum infections. Postpartum infection or puerperal infection is any clinical infection of the genital tract that occurs within 28 days after miscarriage, induced abortion, or birth. The definition used in the United States continues to be the presence of a fever, 100.4 or greater, on 2 successive days of the first 10 postpartum days, not counting the first 24 hours after birth. Other common postpartum infections include wound infections, urinary tract infections, and respiratory tract infections. Mastitis or breast infection is common among your breastfeeding mothers. The most common infecting organisms are the numerous streptococcal and anaerobic organisms, such as Staph aureus, gonococci, coliform bacteria, and Clostridia are less common but serious pathogenic organisms that can cause puerperal infection. In your textbook on box 21.3, it lists the factors that predispose the woman to postpartum infection. Make sure you look over that. Endometritis, which is infection of the lining of the uterus, is the most common postpartum infection. Signs of endometritis include fever, increased pulse, chills, anorexia, nausea, fatigue, and lethargy, pelvic pain, uterine tenderness, and foul-smelling profuse lochia. Management of endometritis consists of IV broad-spectrum antibiotic therapy and supportive care, including hydration, rest, and pain relief. Wound infections. Wound infections are common postpartum infections that often develop after the woman is at home. Sites of infection include the cesarean incision and repaired laceration or episiotomy site. Predisposing factors are similar to those for endometritis, which are listed in box 21-3. Signs of wound infection include fever, erythema, edema, warmth, tenderness, pain, seropurulent drainage, and wound separation. Urinary tract infections, they occur in 2 to 4% of postpartum women. Risk factors include urinary catheterization, frequent pelvic exams, epidural anesthesia, genital tract injury, history of UTI, and cesarean birth. Your signs and symptoms include dysuria, frequency and urgency, low-grade fever, urinary retention, hematuria, and pyuria. Costovertebral angle tenderness or flank pain can indicate upper UTI. Medical management for UTIs consists of antibiotic therapy, analgesia, and hydration. Mastitis or breast infection is common among breastfeeding women. Mastitis is characterized by the sudden onset of influenza-like symptoms, including fever, chills, body aches, and headache. The woman usually has localized breast pain and tenderness and a hot reddened area on the breast. Mastitis most commonly occurs in the upper outer quadrant of the breast. One or both breasts can be affected. Most cases occur during the first 6 weeks of breastfeeding, but mastitis can occur at any time. Treatment includes antibiotics, analgesics, and antipyretic medications such as ibuprofen. The mother is advised to rest as much as possible and breastfeed the baby or pump frequently. You're striving to make sure the mom empties the affected side adequately. Warm compresses to the breast before feeding or pumping can be useful to the mother. And this is just a picture of what mastitis looks like in the postpartum mom. Postpartum psychologic complications. Mental health disorders in postpartum period have implications for the mother, the newborn, and the entire family. It can interfere with the attachment to the newborn and family integration, and it may threaten the safety and well-being of the mother, the newborn, and other children. Mood disorders. Mood disorders are the predominant mental health disorder in the postpartum period. Up to 80% of women experience a mild depression or baby blues after the birth of a child. However, functioning of the woman is usually not impaired. Baby blues are characterized by mood swings, feelings of sadness and or anxiety, crying, difficulty sleeping, and loss of appetite. The symptoms typically resolve within a few days and treatment is not needed. Postpartum depression. Serious depression is experienced by 10 to 15% of postpartum women. It can eventually incapacitate them to the point of being unable to care for themselves or their babies. Postpartum depression affects women from all cultures, although the manifestations may vary. The cause of postpartum depression can be biologic, psychologic, situational, or multifactorial. The change in estrogen and progesterone levels after pregnancy. The woman goes from having high levels of estrogen and progesterone to at the end, after the placenta is delivered, those levels drop very low. Women at greatest risk for postpartum depression are those with a history of anxiety or depression and especially those who have had a previous episode of major depressive disorder in the past, including during or after pregnancy. Fathers can also have postpartum depression, and we label this paternal postpartum depression. Postpartum depression without psychotic features. Postpartum depression is an intense and pervasive sadness with severe and labile mood swings. It is more serious and persistent than postpartum blues. Intense fears, anger, anxiety, and despondency that persist past the baby's first few weeks are not a normal part of postpartum blues. The symptoms of postpartum depression rarely disappear without outside help. Most of these mothers seek help only after reaching a crisis point. The symptoms of postpartum major depression do not differ from those of non-postpartum mood disorders, except that the mother's ruminations of guilt and inadequacy feed her worries about being an incompetent and inadequate parent. In postpartum depression, there can be a loss of appetite or odd food cravings and binges with abnormal appetite and weight gain. A distinguishing feature of your postpartum depression is irritability. These episodes of irritability can flare up with little provocation, and they sometimes escalate to violent outbursts or dissolve into uncontrollable sobbings. Treatment. Pharmacologic interventions is needed in most cases. Treatment options include antidepressants, anti-anxiety agents, mood stabilizers, and electroconvulsive therapy. Psychotherapy focuses on the woman's fears and concerns regarding her new responsibilities and roles in monitoring for suicidal or homicidal thoughts. We can offer support groups, and for some postpartum women, hospitalization may be necessary. Postpartum depression with psychotic features. The most severe of the perinatal mood disorders is postpartum psychosis. It's rare. It affects approximately 0.1 to 0.2% of postpartum women. The disorder tends to show onset within 2 weeks postpartum. However, it can present later in the course of the illness as a depression. Episodes of your postpartum psychosis are typified by auditory or visual hallucinations, paranoid or grandiose delusions, elements of delirium or disorientation, and extreme deficits in judgment accompanied by high levels of impulsivity that can contribute to increased risk of suicide or infanticide. Postpartum psychosis is a psychiatric emergency and may require psychiatric hospitalizations. Treatment is antipsychotics and mood stabilizers such as lithium. Typically, postpartum psychosis is most commonly associated with the diagnosis of bipolar disorder. Care management. Primary health care providers usually recognize severe postpartum depression or postpartum psychosis but may miss milder forms. Even if it is recognized, the woman may be treated inappropriately or subtherapeutically. Identification and treatment of maternal depression must be continued beyond the immediate post-birth period to prevent negative effects of maternal depression on the children of these mothers. Screening for postpartum depression. When postpartum depression is identified early, it is highly treatable. Screening for depression during pregnancy and the postpartum period aids in prevention and early intervention for depressive symptoms. Nursing care in the postpartum unit. The postpartum nurse must observe the new mother carefully for any signs of tearfulness and conduct further assessments as necessary. Nurses must discuss postpartum depression to prepare new parents for potential problems in the postpartum period and discuss ways to help prevent postpartum depression. Nursing care in the home and community. Postpartum home visits can reduce the incidence of or complications from the depression. So sometimes a brief home visit or phone call once a week to check up on the mother can help with the signs of postpartum depression, so that if the visitor notices a change, that they can alert the physician. Referrals. Women with moderate to severe cases of postpartum depression should be referred to a mental health professional, such as a psychiatric nurse practitioner or psychiatrist, for evaluation and therapy. Inpatient psychiatric hospitalization may be necessary, and this decision is made when the safety of the mother or children is threatened. Providing safety. If delusional thinking about the baby is suspected, the nurse should ask, have you thought about hurting your baby? When depression is suspected, the nurse asks, have you thought about hurting yourself? As nurses, we need to make sure that we are providing safety for both our postpartum moms and our infants. Psychiatric hospitalization. Women with postpartum psychosis have a psychiatric emergency and must be referred immediately to a psychiatrist who is experienced in working with women with postpartum depression, who can prescribe medication and other forms of therapy, and can assess the need for hospitalization. Psychotropic medications. If the woman with postpartum depression is not breastfeeding, in most cases, antidepressants can be prescribed without special precautions. A variety of medications can be prescribed. Typically, we use the tricyclic antidepressants and the SSRIs, your selective serotonin reuptake inhibitors. They seem to work best. Psychotropic medications and lactation. Use of any psychotropic medication in a breastfeeding mother is done with consideration of risk and benefits. The risk of not treating the mother versus not breastfeeding the infant prompts providers to prescribe medications that reduce maternal symptoms without harming the infant. Like I said, SSRIs are the most common treatment for postpartum depression. They are also prescribed for anxiety disorders. Okay, loss and grief. With pregnancy, situational life crises can be superimposed on the childbearing family. These crises include parents or families who suffer from infertility issues, premature labor or birth, cesarean birth, gender of the infant not desired. Some people want boys, then they get girls, or vice versa. Birth of a child with a handicap. Maternal death, the mom dies in the childbearing process, and fetal or neonatal death. Grief responses. We know that the grief response differs from person to person, from culture to culture. The overlapping phases in the grief process include acute distress, intense grief, and then reorganization, trying to get your life put back together after the loss of a loved one. Family aspects of grief. Not only do the mother and father grieve the loss, but other family members grieve the loss, the grandparents, the siblings. Communicating and caring techniques. You want to help the mother, father, and the other family members actualize the loss. help parents with decision making. Typically, when you have a neonatal death, especially if it's unexpected, and even when it is expected, it is very hard on the family. And as the obstetric nurse, we play an important part in helping these parents through the grieving process. When I worked on the loss team, when I worked labor and delivery, part of we did certain things for the family. We would take pictures of the infant, we would dress the infant, bathe the infant, we would give like locks of hair, take footprints, handprints. If the family wanted the baby baptized, we could call one of the chaplains. They would come up and baptize the baby. And depending on if the baby was greater than 20 weeks, the parents had to either bury the baby or do or use cremation services. So we had to, before the parents went home, we had to help them pick a funeral home for their neonate that was lost. As the nurse, you want to help the bereaved to acknowledge and express their feelings, normalize the grief process, and facilitate positive coping, meet their physical needs of the bereaved mother, and create for memories for parents to take home. And like I said, we had like a little the violence. I think it was volunteers. They made the little hats. They would make like the little gowns for the preemies that had died, and we had like a hope chest that we would fill with mementos like the footprints, a lock of hair, the blanket, and the outfit that we wrapped the baby in, and any pictures that we may have taken. The cultural and spiritual needs of the parents. You want to provide culturally sensitive care at and after discharge. Provide postmortem care respecting the parents' wishes. Document everything that you did and provide sensitive care both at and after discharge. And typically, if we had a neonatal loss, we would ask the parents if they wanted to see or hold the baby. And I would not put a time limit. If the mom wanted to keep the baby with her for several hours, I would let the mom keep the baby with her. And there were times after the mom, had held the baby and seen the baby, and we wrapped the baby and took the baby to the morgue. I've had several times where mothers have called and said, I want to see my baby one more time, and we would have to go to the morgue and recover the body, and I would have to dress the baby, put the hat back on, find a little outfit, and wrap the baby up and take the baby back to see the mother. It's one of those things that's very hard on the staff as well as on the parents and then the family members. And usually, we had made like a team. We call it the neonatal grief team, and these are nurses who would take the time to help the mom do all the things for the baby, because it can be it is a very sad situation. And what happened was, one of the doulas that I worked with in Pinellas County, she volunteered for hospice, and what they did, they put together a neonatal loss and grief team with hospice. So whenever we had a fetal death, we would call the doula who was over this team, and they would come in and they would stay with the mother all throughout the labor. They would stay with the mother after she delivered. They would do all the necessary gathering of collectibles to give to the mom. So it kind of helped the nurses out quite a bit, because if you can imagine doing, labor and delivery is supposed to be happy, and then to have a fetal death while you could be taking care of a mom who's having a normal labor, and then you have a patient who's going through fetal loss. So your emotions are just kind of all over the place during that time. A maternal death. It's rare for a woman to die in childbirth. The families are at risk for developing complicated bereavement and altered parenting of the surviving baby and other children in the family. It is definitely an emotional toll on the nursing and medical staff. Uh, it is very hard when you have a maternal death, and on top of the maternal death, if the fetus also dies. So there's two deaths that have occurred. It is very hard on the labor and delivery staff if we have a maternal death. So usually when there's a maternal death, we also have like a debriefing, because I mean, the last thing you want to do is have a normally healthy pregnant mom die while trying to give childbirth. And if you think back to the film that I showed, the ER episode, how devastated the staff was when that mom died in the emergency room. Okay, question. The most effective and least expensive treatment of puerperal infection is prevention. What is important in this strategy? A. Large doses of vitamin C during pregnancy. B. Prophylactic antibiotics. C. Strict aseptic technique, including hand washing by all healthcare personnel. Or D. Limited protein and fat intake. Everyone should get this right. You have been force fed the importance of C, strict aseptic technique, including hand washing by all healthcare personnel. This concludes the audio lecture for Chapter 21, Postpartum Complications. Thank you.